it's not just one thing that's going to save the mouth or the world or the gums or the teeth. It's like one thing will help healing by 3%. Something else will help by another 4%. And we're creating these really teeny tiny little good habits that ultimately help us achieve whatever we're trying to achieve.
What's up, dental peeps? It's your girl Irene here with Tooth or Dare podcast. Hold on to your suction. It's about to get slippery.
Are you tired of feeling like a contortionist after a long day working in clinical practice? This message is brought to you by our sponsors at Designs for Vision, who are offering you a 45-day free trial of any of their loops. But I strongly encourage you to try their ergonomic loops called Infinity View. Say goodbye to your chin down, neck cranked, poor posture, dental procedure and practice. All you have to do is go to their website, submit a form in order to get your rep to reach out to you, get measured, and get your loops. And then you get 45 days to figure out if you like them or if there's anything that you want to change. Or you can just send them back. But I don't think you will. So buckle up, get ready to rock the Infinity View loops and say hello to a life filled with joy, comfort, and amazing posture. Thank you, Designs for Vision, for creating these beautiful loops. I can't go back to my old ones. Ever.
Welcome back to another episode, peeps, of the Tooth or Dare podcast with your peep Irene, joined by the Honorable Vic. Welcome back to Op Talk. We're doing part 2 of the SRP question that we had previously answered. So if you didn't hear, if you didn't watch the video from last month about like when to do SRP, and I think the question was mainly focused around how to graduate your patient from a 3-month maintenance back to a 6 or somewhere in between, and talked about like what I do and how I identify it. My like 10-10 rule, 10% bleeding and 10 sites of 4 or 5 or lower. But now I think some of the questions we're seeing are more about the how.
Yeah. What you use.
Yeah. So you've got the thread open. Why don't you just scroll through some of them and like read, what do they say? Like, what do they want to know about?
Tell me more about H2O or irrigation. Can't talk. Sorry.
Hydrogen peroxide. That's hydrogen peroxide.
Yes, it is. I guess I could have just said that.
Yeah.
Hydrogen peroxide irrigation. Is it okay to do after laser? Better benefits from doing before? What probiotics do you use?
Yes.
What is airflow?
Yes. All of those are all in my SRP appointments.
Let's talk about it.
Let's
break it down.
Let's break it down. I'm going to give you this laptop, Vic, because I want you to open up my probiotic lecture, because there's some stats that I want to like quote.
Yes.
What is that lecture called?
RDH Under One Roof.
Yeah.
2024.
Which I am recording this. It's called Synergies of Therapy. Yes. And I'm recording an RDH Extended. Am I not?
Yes, you are.
Yeah. I don't know what the timing of this will be like, but RDH Evolve. No, that's different. RDH Extended. Whatever. RDH Under One Roof Extended. So like if you want to listen to this probiotic component, you can listen to it there. So the stats on probiotics are here. Okay. You hold this while it loads, because you know where those like numbers and stuff are. Now, I recognize that I live in a unicorn place where I get to own my own office, and I get to unicorn treatment plan, and I get to unicorn buy products and do things. So like, I recognize that like what I do may not be what other people are able to do. And that's okay. The goal is that somehow we're able to reduce bleeding and perio probing sites. You just hold on to that for now. And it's all done based on a series of percentages. So like, it's not just one thing that's going to save the mouth or the world or the gums or the teeth. It's like one thing will help healing by 3%. Something else will help by another 4%. Something else will help by another 5%. I think I have that in a slide at the very end, where the goal is that we're doing all of these little teeny tiny things and we're creating these really teeny tiny little good habits that ultimately help us achieve whatever we're trying to achieve. And for me, it's 10% or less bleeding and 10 sites of 4 millimeters or lower. That's my goal. And whatever goals you choose to set, I mean, the AAP is saying that we need to find one of two buckets to put a patient in. They're either in remission, meaning that they're stabilized in those numbers, doesn't mean we're solving all of them, or they're in full health. So when I see a new patient and I'm treatment planning for SRP, the first thing I do is a full mouth probe. Actually, that's a lie. The first thing I do is I take photos. So I'm using I don't use the disclosing agent first because then it's hard to probe with it. But I take photos of areas so that I can look at the contour of the tissue. So I'm identifying if the tissue is bulbous, if the papilla is enlarged or inflamed. I'm looking at where the tissue is. And this will help me calculating my clinical attachment levels versus my loss, meaning height of tissue versus recession. And it gives me a visual of like before I get in there with the probe, what I'm looking at.
And are you taking intraoral photos with a camera or like ortho photos?
Ortho photos, yeah. Most of the time patients are seeing the dentist first. So they're getting a new patient exam done. And in that new patient exam includes our series of pictures. It also includes an iTero scan. So like I can see what the tissue looks like on an iTero scan. I can open it up and you don't have to have the iTero in your operatory. You can have the iTero, like you log into myiTero.com and then you have the patient scan open. I can also use NIRI, my near infrared, on the desktop version. So if I'm getting a 4 millimeter pocket, I need to then decide, is that because there's calculus or biofilm? Is that because there's traumatic occlusion? Is that because there's a restoration that's sub G that's starting to fail or isn't a great restoration? Like what are the reasons why? And then what is my intervention? Because scaling and root planing alone isn't going to fix all of those things. And scaling and root planing alone, even if it is a gingival or a biofilm related reason, it also won't fix that. I mean, I wish that I had an endoscope right now. We went to that course and we listened to them.
Awesome.
And I'm not certain that I'm able to remove calculus to the greatest of my abilities if I definitely can't see it. So rabbit hole. Perio is a rabbit hole.
Yeah, it is.
Moral
of the story.
Which is why we created this resource, which is free for everyone. And it might not be all of the things that you do in your office, but it gives us an idea of where we should be putting things and why.
Yeah. And this isn't concrete. You can add, you can take away.
It's not official. Yeah. The American Academy of Periodontology has not said Irene is a genius and this is what everyone needs to do. It's just, it helps me describe things to patients by showing them something and having them do this tree with me, right? Yeah. Problem, consequence, and solution.
It's a visual aid. It's a workflow aid.
And the chart on the back is kind of identifying what products have been researched. And these are all researched. We haven't put anything in here that doesn't have a series of studies or a meta-analysis because, there's a lot of stuff that's out there that we don't really know what the long-term effects are. So like this is just stuff that has a lot of invested research in to demonstrate what we want to do with a patient. Can you read the stats of how much of a percent does each of these things? So laser, a Restin, which is minocycline, a probiotic, a hydrogen peroxide, a xylitol. Like what do you have there that can give us an idea of without just SRP instrumentation? What are we hoping to achieve?
So for probiotics, there's a 90% reduction in subgingival pathogens.
90%.
20% BOP reduction. And then there's other ones like a 70% halitosis reduction, 49% caries reduction, 35% increase in healing time.
So let's break that down.
Yep.
Because 90% is a big number.
Yeah.
Like huge for something that's very simple to use. Maybe we should just do a whole episode on the use of probiotics because I use it in like 3 different ways.
Yeah.
But overall, a 90% reduction in the subgingival biofilm that is the gram-negative biofilm, the scary stuff.
Yeah.
What about the use of hydrogen peroxide, H2O2? What that has like significantly been studied too.
Which
I think it's like after the probiotic alone stat. It was like in a little chart. Okay, we're back. I have the laptop now because I remember where it was. Okay, so there's a study. Here's the chart of it. That they took 4 different groups. So they took 4 different groups over 6 months, and they started all of these patients with 4 different interventions. So the first group was SRP. It's like SRP alone. Second group was SRP plus laser. Third group was SRP plus hydrogen peroxide. And fourth group, the yellow group, was SRP plus hydrogen peroxide plus laser. And the most significant reduction was achieved in the SRP laser plus hydrogen peroxide group. But if you look at this chart, which we'll embed here, you can see how they follow this group over, I believe it was, a 6 months intervention. So before intervention, immediately after, 6 weeks after, 12 weeks after, and then 6 months after. And the SRP group alone, after 6 months, was basically back to the same.
Yeah.
Like back to the same findings of pathogens. The study's called disinfection protocols of a 980 nanometer diode laser with hydrogen peroxide in critical probing depths, periodontal pocketing. And it was a retrospective. So significant findings, like significant changes between each of those groups. Now, let's say that all you have is hydrogen peroxide, which I believe in this study, it was what was the dilution? I think it was 1.5. Anything between 1.5 and 3 is safe for intraoral use. Like in endo, they're using 3%. Yeah. But if all you have is SRP and hydrogen peroxide, you're already at least a 50%. So I'm looking here, SRP and hydrogen peroxide is the green group. You're at least at a 50% better result within 6 months than SRP alone. And someone messaged about billing for it.
Yeah.
Did you see that one?
Yeah.
There is a code that you can use, an oral irrigation code that you can use to bill. I don't. Because I don't want people to say no to it.
Yeah, because it's so important.
It's so valuable.
Yeah.
I hated SRP until I started to love it again because I was able to actually reach my own personal goals.
Yeah.
And if I can't control those systemic factors or their at-home factors, then the least I can do is control my own factors. So within the first, like immediately after, everything got better.
Yeah.
And but the everything got better meant that the SRP group alone only got 50% better.
Yeah. And it just goes like, overall takeaway is the more things you add, the better it's going to be, the better outcomes. Even if you just add one thing, you're still going to get a better outcome than just doing SRP alone.
Right. Someone will argue that it's like, well, you don't want to throw the kitchen sink at everything.
Right.
So you don't have to.
No.
But overall, conclusively, retrospectively, in this study where how many participants were in this? They took 59 different studies. So they took a significant amount of research, 15 different articles that included 59 different pieces of research that were referenced in those articles to determine this. And it's recent too, like March 2022.
Yeah.
Very recent recent piece of research.
Yeah.
So like this is part of my SRP and planning to do all of those things like laser plus irrigation. I dilute to 1.5% and I use just like a thin gauged device. I don't know how to better describe it. What is it? 27 gauge
like syringe,
0.27 gauge syringe that like clips onto like one of the smaller versions of a monojet syringe.
Yeah.
That's what I use. So with that, lots of questions about Arestin.
Yeah.
So I'm going to give you the benefits first before I walk you through the way to do it. So Arestin in my UOR lecture slide starting at 104, where I show the furcation case and the furcation patient. Post study was done on 2,805 patients treated with periodontal disease with the use of Arestin. Now, the feedback I get from people is like, well, I used it and it didn't work. But they're dropping it into like a 10 millimeter pocket.
Yeah.
And not assessing all of the other things.
Yeah. What is the max 7 millimeters?
Yeah. And like ideal is actually 4, 5, and 6. And 7 is like, 7 without other modifiable things like occlusion or restorations. Like you've got the perfect pocket.
Yeah.
But I wouldn't put it in anything that's greater than 7. No. So they took this study of 2,805 patients, and the study was done on patients with 5 millimeter pockets, and they were assessed every 3 months. And that was what they identified, that after the first treatment, 62% of sites had decreased to less than 5 millimeters. And after 2 treatments, it was at a 67%. So don't stop at 1.
Yeah.
Especially if you're seeing that there's an improvement, like hit it again, right? At 4 to 6 week eval is the perfect time, because hopefully you haven't had enough time for calculus to mineralize.
Exactly.
And then you're able to like go back in there, especially if you still see the site and if it's bleeding.
Yep.
Clean it out again, get a scaler in there again, and then drop in another Arestin. So
instead of waiting till the 3-month appointment.
The wait and watch is not going to help you. Ever.
Not at all.
Like when does that, how often does that happen? Ever. I'm just going to wait for this cavity to remineralize itself, but you're not going to do any of the things at home that I told you to do.
Exactly.
So we're just going to wait until it goes from an E1 lesion to a D1 lesion within the next 6 months.
Yeah. Without any change of habits or anything else.
Right. Exactly. So those are the reasons why hydrogen peroxide and minocycline and laser all combined are really helpful. Now the how.
Yeah.
And that goes to my workflow. So does it matter? This is the question that gets me a lot of times. Like, does it matter if someone is a stage 2 or a stage 3 or a stage 4 or a stage 1 or a maintenance appointment? And this was the question that our follower had, is like, well, what do you decide? What do you do when they're back to remission? I do the same, just less. Maintenance with laser is far greater than maintenance with just going back to hand scaling alone. Now, I also use airflow, and there's research that shows that using air polishing or air debridement, specifically with glycine powder. I think there's some research now on glycerin.
Yeah, there is.
Yeah. I don't know much about it. I know that there's a couple of companies that make air polishing devices that use glycerin instead of glycine. My goal for 2025 is to learn more about them. But so starting with air polishing, that significantly reduces.
That's the key, is start with it before you debride.
Right. Yeah.
Because that's what the research says, is that if it's done before you debride, it has the more beneficial effects.
Why?
I don't remember.
She also has a concussion, so she doesn't.
My short-term memory.
I should just stop asking
exist.
why. That's why she needs a laptop in front of her most of the time. I don't remember.
My short-term memory is gone.
But it said it. I remember the yes.
Yeah.
And I know probably because it's doing a sweep, right?
Yeah, and I know for example, all like EMS in their workflow, they do recommend it before debridement as well.
Right. See, I love my EMS and I love my EMS people.
Yeah.
I don't love calling things a protocol.
Yeah.
And it's no shade. Like I have 2 devices. Like I love them, but I think that until we use research to decide what a protocol, and there's always new things happening. Like there's research on CBD that's coming out. What if the patient has dry mouth? Like not every patient is going to be a GBT patient.
It's true.
Because it depends on the human and what your findings are. So like I didn't call this a protocol. I called it a process.
Yep.
Because it's my process. So incorporation of things early is important. I guess that's the molar of that biofilm story. But incorporating things before a patient starts SRP. So my new patient exam includes a full mouth probe. I print off the full mouth probe. I walk through what perio pockets is. I use my staging and grading section from the Path to Health from Philips, where I show the patient where they are and then where they may be if things don't improve, and then where they should be when things improve. So that's like aspirational and motivational, and then whatever their staging grade is. And then I go through here and I start with is there bleeding? Usually,
yes.
There's bleeding. So yes. So if there's bleeding, I immediately start with the recommendation of a probiotic, whether that be a lozenge, whether that be drops, that this is the at-home component. And then the next question is, are there perio pockets? Usually, and that's 4 millimeters or greater. And SRP could be localized. SRP could be generalized. It could be a whole mouth, could be a whole quadrant, could be 2 quadrants, could be 1 tooth.
Yep.
Exactly. So then I'm doing this therapy on that one area. Is there calculus? Yes or no? So then I start with beginning treatment. And maybe we'll record like a little video of me like doing this, like walking through this. Airflow, biofilm removal, oral hygiene instruction and disclosing agent right away, intraoral photos, any restorations that are of concern that need to be replaced in order to help with our treatment, and then the treatment planning and the presentation. All of that happens before I scale subgingivally. And most of the time in that 70-minute new patient appointment, I don't have time to start, or if I do, I'm starting a couple of teeth on the upper right. I always do right and left. Everyone in my office does right and left. If a patient says to me, well, can you start with the lower anteriors? I say no.
No.
Do you say no?
I say no.
Yeah.
I don't do that.
I say no, thank you.
No, thank you.
Yeah. Unfortunately, I can't do that. Yeah. I need to start. Yeah. I'm OCD.
Yeah.
We all are, because if I call in sick that day and someone else, and I don't know. So
I actually worked with a girl who would always start lower anterior.
Right. Because it's the social 6.
Yeah. But never me.
No. So we all start here, right side, left side. And it's 2 hours at minimum for SRP with laser. Now one of the questions was, when do you do your irrigation? When do you do your probiotics?
Yeah.
I also dip my instrument in probiotics and deliver it straight to the pocket. And normally I do that at the very end with my probe, with a clean probe that I've dipped in hydrogen peroxide, that I've wiped. There's no gunk on it. And we can do the probiotic op talk at another time. But there's like a delivery of that. Now, in the sequence, I think Sally asked about the sequence in the comments. The sequence starts airflow, debridement, oral hygiene instruction with disclosing agent, SRP on the right side. So patient's coming back for a second appointment. I do disclosing agent again because I want to see, and sometimes it's immediate, but sometimes it's like a month later that they're coming back to start SRP. They need to book all of those appointments at that appointment. So they're booking SRP1, SRP2, and the 4 to 6 week re-eval and the 3-month maintenance. They're booking 4 appointments before they leave. Yeah. Because what happens?
what happens is your schedule gets full and then it goes to, oh, I guess we'll do 4 months, or, oh, I guess we'll re-eval in 1 month or 2 months or whatever. Yeah.
Or you don't have time to finish the second SRP.
Or that. And then or they cancel and
you do SRP on one side and then it's 3 months later, they're coming back for SRP on the left side and the right side's a mess again.
Yep.
So they're booking all 4 of those appointments. And when they cancel them, it shows up on the file that, okay, well, you're moving 1. Now we need to move all 4 of them. Yeah. And patients don't like doing that when it's already in their schedule. So they figure out how to make it work.
Yeah.
So we do that. And then I start with disclosing agent. I will remove all biofilm again. It's usually pretty quick. And then I go in with I start with ultrasonics first. So another one of my flexes and another one of the reasons why I don't like to specifically follow just like one particular workflow is because I use Cavitron and I use Piazon in the same appointment. I like them both. I mean, I like the different tips that I can use on my ultrasonic with my Cavitron.
Yeah, me too.
I like that it swivels. Like my biggest qualm with my airflow is that it's so hard. I feel like sometimes I'm unscrewing the top of my airflow with it. So I like both. I like the very teeny tiny thin certs, like the purple ones.
Me too.
And I like the right and left sometimes better than with my Piazon because they're thinner.
Yep.
So, I mean, I go back and forth. I will say that I probably do the bulk of my calculus removal with the Piazon just because it's so easy and I'm already there. Like I've already used my airflow and now I'm like the device is right next to me.
Yep.
But then when I go back to feel and I know they recommend to feel with the Piazon, but it's too thick for me.
The handle. Yeah.
Yeah. I need more tactile. I check with my 1112 Explorer. And then I go back with the ultrasonic, and then I'll hand scale.
Yeah.
We talked about SRP kits.
Yeah.
I have 2 instrument kits out. So I have my standard kit, 11, 12, 13, 14, 7, 8, Nevi, 204S, that one. And then I have my mini, which is the mini and the rigid version of every single one of those instruments. 11, 12, 1, 2, 7, 8, 13, 14. And then I have the rigid versions. I even have a mini universal, a 2R2L, smaller, which is in that kit. And I love that. And I irrigate as I go. I also dip my instrument in hydrogen peroxide as I go because it bubbles all of the like granulation tissue up and I wipe it. Yeah. So I irrigate as I go. So the question that Sally had about like, when do you irrigate, before or after laser? Always before.
Yeah, always.
Always before. You want to get like
everything out of the pocket before you laser.
Yeah. I want nothing in there.
No debris.
Nothing. No debris, no granulation tissue, no calculus. So I'm using hydrogen peroxide as I scale. I'm irrigating with hydrogen peroxide as I go, as I'm done. And then when I'm done that whole area before I laser, I go back in one more time with a full quadrant irrigation. My HVE's in there. Sometimes I'll use like a Zerk Mr. Thirsty that has like the tongue pulled back.
Yeah.
And it clips into my high volume section. I've even used an isolite before. Like those are nice because they light up. And then laser. Yeah. Now sometimes I'll do laser at the beginning. If I see there's a ton of biofilm, then I'll use my laser has like a little curing light attachment to it that helps with dentinal sensitivity. But sometimes I'll take that and I'll go over all of the biofilm first to reduce the bacterial load or like the bacteremia component. I'm not so good with that though.
Right.
Because I want to do laser at the end. I feel like to me in my brain, and this is totally wrong, but in my brain, it's like laser's the clean part.
Yeah. Yeah. I've never done it before.
Never lasered?
I've done it. Sorry, I've always done it after.
Oh, like right,
is what I meant.
Right.
Yeah.
And then the last thing I do is Arrestin, localized Arrestin, if necessary. But the thing with Arrestin is you want bleeding, right? Like you don't want bleeding, but you want the pocket to not be dry, which is great because after you've lasered, you get this like clear, thin, very viscous, bright red blood. That's how you know you're done instead of like the murky stuff. And then you drop an Arrestin in there and then you're done. Now, some people say, well, do you do Arrestin and also probiotics? I don't in that pocket.
Yeah.
So let's say there's like a lower right first molar.
But you would do take home probiotics.
I would do take home. I probably already started it. Like I probably already started the probiotic at the new patient examination before SRP. And then in the other areas, in the other pockets, like I'll drop a little probe. I'll take my probe, I'll dip it in the probiotic. I'll walk it around. Like you don't need a ton because the entire mouth gets like 3 to 5 drops. Or I'll put some on their tongue and then have them smear it. So that's what an SRP appointment looks like.
Yep. Patient dependent.
Yeah. Should we do a different episode on 4 to 6 week evals? Because those are deep too.
Yeah, those are deep.
Nicole, how are we for time? 33 minutes. We talked about SRP appointment for 33 minutes. I think we're done. I think we're going to do another episode for the rest of the stuff. We're done. Yes.
We could talk all day.
We do. We definitely do.
We need a timer.
Yeah, we need a timer. Okay. Until next time. Peace out, peeps.
Bye.